But yeah, this is what everyone is talking about. The diagnosis, prostate cancer, pretty aggressive form. Um, is this something that you have diagnosed yourself quite often, or a
Yeah,
similar type
well,
of prostate cancer?
yeah. So I am a medical oncologist with my area of expertise is prostate cancer. And so at this point in my career, the majority of my patients that I treat are patients with prostate cancer. And unfortunately, those patients tend to have metastatic disease, which my understanding is that President Biden has, based upon the news blurbs that I have seen, and I actually lost Janet. I also lost my father to prostate cancer. So this is very near and dear to me, and my heart goes out to the Biden family, and really the whole nation when we have one of our leaders diagnosed with an aggressive form of disease.
Well, thank you. Thank you for sharing that. The treatment I've been hearing that I guess the upside or the better news in this is that it can be treated with hormone therapy. What exactly is that?
Yeah, so prostate cancer, the prostate cancer cells are very sensitive to the hormone testosterone, and so when doctors talking about hormonal therapy, those are treatments which can be given in a variety of forms, either pills or injections. Typically, they are treatments that lower the man's testosterone level. So I describe it as taking away the fuel to the fire of the prostate cancer cells. So the cells, think of the prostate cancer as a barbecue, the fire pit. The lighter fluid is the testosterone, and we're throwing a bucket of water onto the fire, kind of suppressing it down. Hormonal therapy is not curative if the disease has spread outside of the prostate. Now, oftentimes, we will add additional medicines onto hormonal therapy. Those additional therapies are what we call targeted therapy, which target the prostate cancer receptor and also suppresses the prostate cancer cells seeing testosterone. And we're making great advances. So when we add on hormonal therapy and then add on an additional agent, which is typically a pill, we call that doublet therapy. And in some cases, if patients have what we call high burden disease, we will add on chemotherapy. A doctor like myself, a medical oncologist, often will be the one who will deliver chemotherapy. So, and I've been doing this almost 20 years. We've made lots of advances, and
Hmm.
I think it's good to know that we anticipate President Biden to live with this disease for many, many years, as
Okay.
opposed to like weeks or months, even though the disease has spread, because our advancements have improved so much.
Well, that was going to be my next question. The prognosis from everything that you've heard and the knowledge that you have, and given his age, and any other issues that he might have, you see some positive news in the prognosis.
I do. So I'm sure he'll be in great hands with doctors there. They'll be up on the latest and greatest, and there have been lots of advancements. So we would anticipate what has not been shared is what President Biden's PSA level is, or prostate specific antigen. And so that will be one of the ways that we can follow it once his response to treatment is. We would anticipate with hormonal therapy that his PSA would go down. I don't know if that's elevated. I am not part of his treatment team, but that would be one of the ways. In addition to pictures, we now have PSMA, prostate specific membrane antigen PET scans, which are very, very sensitive of finding the disease and allowing the doctors to pinpoint treatment strategies uh, in 2025.
Now the number that they came out with that was a nine. That P the 6 to 10. That's not the number you're talking about, is it? Or
No,
okay, okay,
that is what's called the Gleason score.
all
The
right.
Gleason score is a number. It's actually two numbers. It's a number of 1 to 5, and what you do is you add up the two, the most when you look under the microscope, the aggressive cores that are involved of the diagnosis. And so President Biden has high risk disease because it's been shared that he has Gleason 9 disease, which can behave more aggressively than a lower Gleason score. So the fact that his Gleason score is higher, the highest being 10, lets us know that he has a high risk disease, which likely explains that why his disease could have spread in a shorter period of time. And I don't know his history, how closely he was being followed in terms of PSAs, but you can have a relatively sudden rise in someone's PSA and symptoms. That's one of the struggles of difficulties of prostate cancer is oftentimes patients don't exhibit any symptoms before it has metastasized. But thankfully, they were able to kind of find the disease based upon just having some difficulty urinating symptoms that were put in the press.
So it is, how likely is it that this is something that developed quickly and wasn't something that was occurring while he was still president?
Not knowing the details, it's hard to I could only speculate that the fact that he has Gleason 9 disease, that this could have developed over a short period of time, as opposed to a long period of time. And we also don't know, it hasn't been shared whether he had prior treatment of prostate cancer or not. That information I don't know. So it's tough to speculate without having, this would be a hour-long consult visit when I get diagnosed with the patient, and I don't have all the information to provide, great feedback for you.
Well, when you say that a Gleason 9 is something that can develop very quickly, just from your experience, how quickly could something like that develop?
It could develop with the Gleason 9. We could develop into metastasis in months as opposed to years. It's not a days or weeks kind of a thing, but it's something that could have developed relatively quickly, where he was totally without symptoms, where he now develops symptoms.
Yeah, so obviously a lot of people are concerned about, just his health right now, and he is advanced age. How will that play into his treatment?
Yeah, so one of the things I embrace as being a medical oncologist specializing in prostate cancer is you need to take care of the whole patient. So you need to work with other doctors because prostate cancer typically is a disease of older men, and so you have to factor in someone's heart issues, their mental capacity, they're having any pain symptoms, their diabetes, a variety of things that you put together. So one of the things I enjoy about taking care of prostate cancer patients is the collaboration you have with other doctors. So the treating oncologist will need to work with all of President Biden's doctors to find the right balance of treatment options, looking at how aggressive can one be. So not everyone requires chemotherapy. Not everyone can tolerate chemotherapy. So, it's all to factor in, but I would anticipate that he would, at a minimum, be placed on hormonal therapy. More likely than not, they would probably look to a class of drugs called androgen receptor signaling inhibitors. There are several possibilities that can be chosen from. And I'm always want to make a plug for clinical trials. So, that there are some very novel treatment options available. And since President Biden has children, you'd want to know the genetic component. So 10% of men with a high risk disease that President Biden has, as well as metastatic disease, can have what we call a germline mutation that can be passed on in the Biden family. There's what's also called somatic mutations. Those are mutations that can happen that over time can develop over the course of treatment with his disease. And again, I would anticipate that President Biden would be treated for his disease over many years as opposed to many weeks or months.
And what would you say the call to action is for for all men paying attention to this diagnosis?
Yes. So pay attention to your body. And also, you might not have any symptoms. So men should have be getting regular PSA testing. I'm an advocate for African American men should start at age 40 to 45 to begin that testing. And for other men, age 45 to 50 to begin testing because there's a higher incidence and early onset of prostate cancer in African American men. But all men, definitely by President Biden's age, should have had PSA testing, at least initially, and should be followed along. And work with your primary care physician as well as urologist, who are the typical ones who do the initial diagnosis because they do typically perform the biopsies.
Okay, well, that's very great information, and that's all I need. And I really appreciate again you taking the time to talk to me.
Thank you. Take care.
Okay, you too. So this has been the big topic over the weekend, this news about former President Biden and his diagnosis. From what you have heard and been able to read and gather, how would you describe his prognosis?
Well, I will tell you that prostate cancer is a very common disease. Uh, I do believe if we men live long enough, I think every one of us is going to get a prostate cancer. It almost seems like a natural part of aging. In fact, that gland, the prostate gland, starts going bad on us when we're very young. About the age of 25, the cells within the gland become abnormal. As the decades roll by, the whole thing swells. It chokes off our bladders. We just can't pee the way we used to. And at some point, we're just no longer willing to call it a benign enlargement of the prostate. And you have to start calling it prostate cancer. I just want you to recognize that this is not an all or none phenomenon. It's not like, a year ago there was no cancer and you suddenly caught a cancer. It's not like catching a cold. It comes on over a long period of time and it ends up being represented by a very broad series of changes. And some of it is real quiet and just this side of benign. And some of it is very aggressive and almost certainly going to cause trouble in the future. And what we do to get a handle on this is we rate it on a scale called the Gleason scale. Dr. Gleason worked out this way of categorizing these cancers based on how it looks under the microscope. And the Gleason scoring system runs from a low of 2 and it goes up to a high of 10. And what has been reported in the news is that this is a Gleason 9. That is obviously a very aggressive cancer. They've also reported that it has, in fact, already spread, that it has spread to the bones, which is a very common place for prostate cancers to spread. But they have not given us details of the of the case. That there are patients who have widespread disseminated metastases with hundreds of spots throughout their body, and there are other patients where you have very limited spread, maybe 3 or 5 individual spots. And we actually have a new classification for that. We would refer to that as oligometastatic disease rather than regular metastatic disease, and it probably has a more favorable prognosis, and we actually treat it more aggressively. So we really don't know what the president has. I can only assume that he has good doctors who are taking proper care of him. But my concern is that my patients and the population who we serve are going to see this on TV and be frightened. It looks like this snuck up and he suddenly caught a cancer and people are going to be wondering that they might just catch a cancer, and it doesn't work that way. We can screen for it. We can watch for this cancer for years and years. The PSA, that screening test, is actually quite effective. Physical examination, the rectal examinations that men really don't like, but which I find to be a very effective way of looking for prostate cancer, can in fact find the disease when it's early and curable. And so I think the takeaway point here is that screening works. Screening is important. There's a critical difference between finding a cancer that is late, that has spread, where we have very limited options, and a cancer that is very early and almost certainly going to be cured. And that just takes attention. It requires screening.
Well, we are hearing from a lot of people who seem to think, oh, there's no way that this could have happened so quickly. But then yet I've heard that this type of aggressive form of cancer can develop over a period of just months. What do you say to that? You're saying that
Different cancers behave differently. There most certainly are aggressive forms of cancer in other parts of the body that might have been undetectable 6 months ago, and now we suddenly are able to see a nodule no longer, something is growing quickly. Prostate cancer isn't like that. It does, in fact, come on over a much longer period of time. Now, the way we screen, we talked a little bit about PSA, prostate-specific antigen, as a blood test that we perform. And if the blood PSA is elevated, well, you have some concern. If it's not elevated, well, you feel a little more comfortable. But this is a different, a difficult process. As we get older, the PSA goes up naturally. And so there's always some elevation of PSA, and the older we get and the bigger our prostates are, the higher the PSA is going to be. So at what point is the PSA indicative of a cancer? What point is it a PSA that's so high that we need to biopsy to prove whether or not there is a cancer? Well, that's not a clear-cut situation. It depends on the patient, it depends on other medical conditions that the patient might have that might be affecting PSA, and the judgment of the doctor who is taking care of them. And so, yeah, you could have somebody who perhaps had an elevation of their PSA, and maybe there were other problems surrounding this. Maybe he had a prostatitis, which is an infection of the prostate that can cause an artificial elevation of the PSA. Or maybe he had a urinary restriction and had some surgical procedures that may have driven up the PSA. And so the PSA may not have been recognized as an indicator of the cancer, but the cancer has certainly been there for quite a while. They're announcing now that, okay, that the cancer is present. They've identified that he has metastatic disease. He's going to be requiring treatment, but no, the cancer did not just come up. The cancer has been there. Why it was only diagnosed now? That's a question for his physicians. But this is a private citizen, and I think he's due a certain amount of privacy and allow them to care for the cancer in the way that they need to. I just don't want men to be worried that this is a silent killer that will take them in the night. It is not. Prostate cancer is a slow, smoldering disease, and we can, in fact, effectively find it at an early stage. And in fact, we have a cancer screening here at the Proton Center in Hampton, and that will be the last week in September. It's our 4th annual screening. We do it in concert with Centara. Hundreds of men show up, and we do exactly that. Rectal examinations. You can't get away from that. And PSAs, and we are helping men to find cancers early. Early cancer, easily treated. Late cancers, not so much so.
Well, we're hearing a lot about hormone therapy for the type of cancer that he has. Is that, does that sound right to you?
I talk a lot about hormone therapy, and you read it online, you're going to read about hormone therapy. But let me make this clear. It's not hormone therapy.
Okay.
It's anti-hormone therapy. Prostate cancer grows under the influence of testosterone. The male hormone is fertilizer for this cancer. It makes it grow, makes it spread. We can give a drug that blocks the action of testosterone, and that kicks the legs out from underneath the cancer. Cancer can't grow, cancer can't spread, and our treatments become actually more effective. And all that is a very good thing. Problem is, men need their testosterone. You knock the testosterone out of their body, you lose muscle mass, you lose strength, you lose endurance, you get heat intolerant and emotionally unstable. It's menopause. We're putting men in a chemical state of menopause, not a natural thing to do for them, but it's temporary. It's for a period of time. We get the cancers under control, and when you stop the drugs, they go back to normal. So that's the hormone therapy. And when they talk about hormone therapy as the initial treatment for President Biden, fatigue, a loss of muscle mass, a loss of strength, a lack of endurance, that's what we would expect. But it's because we have artificially depressed his testosterone level, and that's why he would feel that way.
The type of therapy that you do there, the proton therapy, is that something that could come into play with what he has, the type of cancer that he has?
That he has metastatic cancer, and the treatment of a metastatic prostate cancer has evolved tremendously during my career. When I was in training at MD Anderson many, many years ago, metastatic prostate cancer was an incurable cancer. And our thought was, well, you can't ever stop it, so why try? You leave it alone. And what we do is treat for symptoms. We would watch for pain, and I would treat a painful lesion and relieve the pain. You treat a spot that's bleeding or that's causing a neurologic dysfunction. But because you can never get ahead of it, you wait for a problem, and then we would play catch up and treat the problem. Well, I'm not sure that that is really the best way to approach it. We have much more aggressive ways of treating even metastatic prostate cancers. And as I said earlier, a metastatic prostate cancer with isolated sites of disease, a small number of areas, that is very treatable. And yes, we would aggressively pursue both hormonal therapy, systemic treatments. And by the way, we have many agents beyond simply the hormone treatments that have been around for decades. There's actually some chemo that may be effective. There are new immunodrugs that are sometimes brought into play. We have radioactive isotopes that we inject into patients to treat them. So there are many ways of taking care of the patients with a metastatic disease, but it really depends on the sites of metastases, the total number of areas, and medical condition, which of these different drugs and treatments you'd actually be able to tolerate. So yes, radiation and proton beam radiation can often play a role in the treatment of metastatic prostate cancer.
Well, I thank you for that. We will also probably put this on our app, our streaming service that we have.
Yes.
We'll be able to put the entire interview on that. So I really appreciate you taking some time. And I mean, that was a pretty good lesson.
Very good. Did you have any other more specific questions?
Well, I think the biggest thing is just, for his age, how that was something I wanted. How does his age play into all these different possible treatment options?
It's not so much his age, it's his medical condition. And what will he or be able to tolerate or not tolerate, and how long are they going to run these various regimens? This is something that's individualized, and as I say, I'm sure he has the best of care, and his oncologist will make appropriate recommendations. But that varies, and certainly, the aggressiveness with which we would approach an 80-year-old man is rather different from the aggressiveness with which we would approach a 50-year-old man with similar stages of the cancer. But he will be treated. Simply being 80 years old doesn't mean you throw in the towel and don't try. They got to go for it. They will almost certainly have already started this treatment. It will very likely be one of these anti-hormonal agents as the initial therapy. And you run it for a couple of months and rescan and see what sort of response you're getting. They look at the PSA. The PSA should be plummeting, and wherever these spots are on the bone, they should be improving. And based on that, they might decide what the next step would be.
What is your call to action with this discovery? What? Okay.
Get PSAs, get physical examinations, start young and never stop. It is a very easy thing to do. There are cancers that we have a hard time looking for. Colon cancers. If we found all of those early, they would all be cured. But, well, that does require a surgical procedure. You have to book it with your gastroenterologist. And, it takes time out of your life, and it's expensive. And we do a pretty good job with screening for colon cancer, but it's not an easy cancer to screen for. Prostate cancer is a PSA. It's a blood test. It's part of a battery of tests that most people get every single year. It's hard to take the PSA out of the group of tests that are being performed. And I think that there are people who should start particularly early. Patients who have a family history of it, we know are going to be at greater risk. We know that African Americans get this cancer at an earlier stage and a greater rate, and they, in fact, die of it more often than the rest of the country. And that requires additional diligence and additional screening. But screening makes a tremendous difference here. You find it early, we cure virtually every one of them. You find it late, it's a very different story.
So you should start this screening at what age if you don't have a
at the age that your doctor recommends for you. And as I say, I'm very liberal with it because I consider it to be a non-invasive, inexpensive scan. And if you have a family history starting at a young age, it can't possibly hurt to get it. And I think a more important question is there an age at which you would stop PSA? And, there is a push to say that, well, you get old enough, maybe you live long enough. What are we going to be looking for a prostate cancer for? It's a slow, smoldering disease. It can take a long time to take your life. Maybe after a certain age, you simply stop. You just don't get the PSA anymore. And that bothers me very much. I think that there is no expiration date stamped on my patients, and my goal is to get everybody to 100, isn't it? And we should be doing PSAs in everyone. Why would we simply stop? At what point is it no longer important to care for our patients? And so, yes, I think you start early and you continue. And the reason is that it can come even in later years, and you find it early, we have very effective remedies for it. So.
Absolutely. All right, doctor, thank you so much.